Dámy a pánové,
Ladies and gentlemen, very good morning to you. I would like to welcome you most cordially to our roundtable dedicated to inequalities of care, unequal access to oncology care. Oncology care for patients in the Czech Republic over the past 15 years has seen major success. And little do Czech patients realize what care they have available, what high level the care has, and how much work has been done over the years, especially centers, dedicated centers have been established, the quality of care has been enhanced, etc. This, however, doesn't mean that there wouldn't be any challenges ahead of us that we are to meet. And naturally, it also coincides with activities at European level. As you know, there is Europe's Beating Cancer Plan, EBCA, which is not just an inspiration, but also a task for us here in the Czech Republic. One of the 10 key initiatives in this plan is reducing inequalities, disparities, and access to care. What we say always is that care for oncology patients is accessible. But if we look behind the scenes a bit, surely there is room for improvement to be found. And this is exactly what we'll talk about at our today's roundtable. We have highly knowledgeable speakers. I'm very happy that they've found that I'm joined us. I'd like to welcome Deputy Minister of Health, Mr. Jakub Dvořáček. Good morning. Good morning to you as well. The Director of the General Health Insurance Company, Mr. Zdeněk Kabátek. Good morning as well. And then we have Associate Professor Jana Brausová, who's joined us online. She is the President of the Czech Oncology Society and head of the Oncology Clinic of the Second Faculty of Medicine Charles Teaching Hospital, not all University Hospital. And I hope we can see her. Oh, she's behind us, not in front of us. Oh, yes, she is on the screen in front of us as well. Good morning, Mrs. Brausová. I hope you can hear me. Good morning. My apologies. We also have an event dedicated to novelties in oncology, so I'll try to dedicate my attention to both events. Thank you very much for joining us online. I would also like to welcome the chairman of the Czech Society of Hematology, Czech Medical Association of Stapurkyně, Professor Jiří Majer. Good morning. I would also like to welcome Marek Svoboda, director of the Masaryk Cancer Institute, Brno. Good morning. And we also have here head of the Institute of Pharmacology, Faculty of Medicine, Masaryk University, Radkina Demlova. Good morning. Then we have here Kateřina Kopečková, Deputy Head for Science and Research of the Oncology Clinic of the Second Faculty of Medicine of Charles University. And I'm very happy that we have here also the chairperson of the Voice of Oncology Patients Committee, Cancer Patients Voice, Petra Adámková. By way of introduction of today's deliberations, I would like to ask Kateřina Kopečková to deliver a presentation to open the topic. Thank you very much. Good morning, ladies and gentlemen. Thank you very much for the invitation to this event, and thank you for giving me a chance to present here. The presentation will be a source for the follow-up discussion. Europe's Beating Cancer Plan has already been mentioned. It was adopted last year at a very high level. It's one of the key initiatives at EU level for this term of office, the new term of office that started last year. It focuses on prevention, early detection, diagnostics, and care, quality of life, not only of patients receiving treatment, but also of cancer survivors. And one of the key themes is how it correlates with the National Oncology Plan. So that's why I have put in the NOPSC, that's the National Oncology Plan. So prevention and early detection are covered by that, plus diagnosis and treatment, as well as quality of life of cancer patient and survivors. So there are also 4 strategic goals of the National Oncology Plan. Europe's Beating Cancer Plan highlights the need for innovation, digitization, use of new technologies, and research. This is a slide providing information about the mission on cancer, one of the 5 missions of the European Commission aimed at improving the lives of EU citizens. And a fundamental idea of the mission on cancer, you see that the goals are similar: prevention, diagnostics, and quality of life. You see that the targets are quite ambitious, and that is to decrease mortality by 1/3 by 2030. Then there are programs funded under the Horizon program, and naturally it also ties to BCA, the Beating Cancer Plan. And here, if we would look at some of the flagship initiatives, what is also a very highly ambitious initiative is to have 90% of the whole teenage population, both girls and boys, vaccinated against HPV. This year, the European Cancer Imaging Initiative is to be completed, the aim of which is to come up with an atlas of images of all cancer diseases that should be freely available, both scientists and clinicians, to be used in hospitals for research purposes. And another key goal is to use this imaging atlas for the use of AI in assessing X-ray images and diagnostics. Within EU for Health, for the years 2021 to 27, a whole range of activities are taking place that should help to fulfill the Europe's Beating Cancer Plan. I have highlighted 2 out of these activities that both national oncology centres plan to take part in. One of the tasks is to establish a network of comprehensive cancer centres. This is a mapping project because naturally the situation in the Czech Republic, Poland, Bulgaria, France, etc. differs. So this is a very interesting initiative that is a pioneering initiative to digitization and data sharing, aiming at creating an ecosystem of patient information, information about rare diseases, and sharing between individual providers and researchers. The Mottol Teaching Hospital and Masaryk Oncology Institute aim to take part in that. Let me briefly touch upon one of the key initiatives that we'll discuss also from the national perspective, and that is to establish the European Cancer Inequalities Registry. The aim has been to collect and have data about inequalities, disparities, whatever you call it, between the individual member states from various perspectives, because there are differences between countries, regions, differences in terms of income, educational attainment, etc., and tie that all to the fundamental underlying goals such as prevention, early detection, diagnosis, and treatment, quality of life. And overall, this cancer burden, as we call it, that is cancer burden on the social systems and others. At present, on EC's website, this app is already available, and here you can find the individual inequalities, that is, tumors, imaging methods, treatment, etc. And I have selected just this one slide out of that. Czech oncology, indeed, it has achieved many successes. So, for instance, reducing mortality is one of those, and we have mortality comparable to Germany or the Netherlands. This year, new data from GlobalCan have been published that has only confirmed other reports, such as State of Health prepared by OECD, about the readiness of the Czech healthcare system, or Index of Cancer Preparedness, published by The Economist. So we can see that in both incidence and mortality are being reduced in the Czech Republic. Survival rates are going up. We also see patients who survive cancer and then have secondary malignancies sometimes. As for the situation in the Czech Republic, here I have a quote of the vision in the National Oncology Program, and that is to ensure that each and every citizen of the Czech Republic has a possibility of prevention of oncology disease, and should cancer develop, then highest quality of care and treatment and quality of life, regardless of the geographical area or stage of the disease the patient has. There mustn't be disparities between patients in rural areas, patients in urban areas. So that's the regional disparities. And then there is the social disparities. So, for instance, some patients may live in the vicinity of the cancer centers. However, for some, it may be difficult to get to these dedicated centers. So this is one of the bottlenecks that we see in the Czech Republic. Unfortunately, that the social and health systems are not tied enough to address that issue. Then there is the issue of diagnosis. For instance, the rare tumors, the orphan drug regulation. We also have seen an amendment of Act number 48 that makes it easier for orphan drugs to enter the system. From the perspective of health insurance, we clinicians, as well as payers, see differences in availability of innovative therapy. When we speak about disparities, naturally we should have the situation mapped. The previous Roundtable was dedicated to health data, so I won't really go into that. But let me say that for us, what's key is the National Oncology Registry. This is our Czech family silver, or even gold, I can say, compared to neighboring states. And in terms of digitization, I would like to point out the European health data space envisaged for mid-next year. That should make patients' access to their data easier. There is also one initiative related to that, and that's the European Cancer Patient Digital Center, which envisages the establishment of a hub with health data of patients who, naturally, on the basis of GDPR, would have access to the data and could handle that data accordingly. What remains a problem is to compare the individual providers of care as concerns quality of care, because these are sensitive data. And naturally, in the large centers, complicated patients are concentrated. So the mortality and survival rates don't really tell us much about the quality of these facilities. Currently, several workshops are ongoing, one dedicated to HSPA, Health System Performance Assessment. So this is an initiative based on WHO and OECD methodology. In the Czech Republic, all major stakeholders are taking part in that effort. And actually, we also have to take a look at where treatment and care is provided, screenings are done, etc. And then there is prediction, epidemiological and also demographic aspects there, and naturally also medicines that are quite innovative and costly will be on the rise in the future. So we need to do horizon scanning. Here, I've got a slide dedicated to the incidence of lung carcinoma, lung cancer in the early and late stage. Why are there such differences, disparities between the individual regions? This is due to multiple factors, for instance, smoking, educational attainment, failure to send patients to the cancer centers, etc. Last but not least, the patient pathway, whether it's equal or unequal. From the beginning of the year, we've had a new screening of lung cancer, so we are the first to introduce that. As for diagnosis, so that should be done in the centers. There should be a multidisciplinary team involved that should be praised indeed, and all patients should go through that and should obtain the algorithm of treatment. I'm not saying that all the patients are going to receive the center treatment, but the multidisciplinary teams should definitely be involved. I have touched upon availability of innovative therapy. When I was preparing my presentation, I realized that the methodology we use, quality of life, and ICER and other things, well, that has been unchanged for 10 years. However, the situation has changed dramatically. Medicines have changed. Also, the criteria based on which registration is granted. And what we as clinics are concerned about is that some payers interpret Section 16 differently. So that is reimbursement treatment. So patients with the same diagnosis have the treatment reimbursed by one health insurance company, but not by another one. So much from my side. Thank you for your attention. So these are my topics for discussion. Thank you very much. So that was Katarzyna Kopeczka. And perhaps one question, if I may. Do you think that Europe's Beating Cancer Plan is perhaps too ambitious for the Czech Republic, or do you think we're going to reach it easily, or are there multiple objectives to be reached and we're going to reach some and not others? I think it's a mix of everything, a number of things contained in the Europe's Beating Cancer Plan. The Czech Republic has already met. We have this network of comprehensive oncology and hemato-oncology centers. So this is one of the great milestones the Czech Republic has already completed. Where I believe we are lagging behind is availability of innovative medicines. And also actually involvement of patients and patient organizations in the regulatory processes. However, the amendment to Act number 48 has changed their roles, so they can actually have a word and they can intervene in the assessment of new medicines. Thank you very much. And now I'd like to hand over to the Deputy Minister of Health, Jakub Dvořáček, to tell us how the Czech Republic is doing in terms of fulfilling the Europe's Beating Cancer Plan, what activities the Ministry of Health does for that sake, and is it realistic that expectations in the Czech Republic be met?
As the previous lecturer had mentioned, we are doing quite well. And what is really key is to tell you something about our future plan, what steps we should implement in order to interlink activities of Ministry of Health and other entities such as Health Trust and so on. Last week, I had a chance to check the Vita report data, that means data prepared by the pharmaceutical industry, which is, I would say, a guarantee that the pressure of the state won't be present there to present data in better way than the reality is, and we are focusing on the modern state-of-the-art therapy, modern state-of-the-art medicine, which is great. I think it's a good development, and I think there is no major change expected. At the end of March, 30th of March, the government adopted the National Recovery Plan. That means we have made one more step towards the future, and we are preparing individual goals, challenges which are interlinked to National Oncological Plan, which is again linked with the Europe's Beating Cancer Plan. So the activities are done and they are quite thorough. Maybe I would like to highlight a few changes that the Ministry of Health had discussed in recent months, speaking about National Recovery Plan to strengthen oncological treatment and care. It's a 6.2 National Recovery Plan on the cancer treatment and care. What is necessary to highlight is that the path we would like to go and changes we have made are as follows. We have not entered into the total financial allocation, but we have rather highlighted development of regional centers, the important centers located in Prague and Brno. So I'm talking about Teaching Hospital Motol and Masaryk Oncological Institute. So we have reallocated funds to provide specialized oncological treatment in regions, which is important in my view. Then individual regions should reflect the current situation, outcomes, and based on that we should develop further projects that will then also reallocate hard funds, that means investment and facilities, equipment of individual oncological centers, both for traditional oncology and hematological oncological treatment. So that's one area which is based or related with a National Oncological Plan prepared by the Czech Republic for some time already. Speaking about the part of it, it is incorporated International Recovery Plan, and in fact it is being commented right now, and I guess that this document should be submitted to the management meeting either this week or next week. So I would say the intra-ministerial comments will be processed in 2 or 3 weeks. One of the milestones was set for June, so we will fulfill it because then once agreed by the ministries, we should submit it to the government and we should follow with the implementation of further steps. Oncology prevention and screening within oncology is one of the priority of the Czech Ministry of Health within the preparedness for the Czech presidency. In fact, one of the first events Czech Republic is preparing is a conference on oncology, which is prepared for the beginning of July, first half of July. And the outcome of the July conference should be a call for action, which should be then negotiated in the September informal meeting of Ministries of Health conducted in Prague. So I would say this is a brief summary of what we have prepared on behalf of the Ministry of Health related to cancer. So 13th and 14th of July, we plan to organize this conference. Mr. Schuppe, one of the coordinators of the Europe Beating Cancer Plan, is also invited for this conference, and other speakers that participate on fulfillment of this Europe Beating Cancer Plan to be performed throughout Europe. Then the example of good practice I think is demonstrated in our plan. Thank you very much, Mr. Vice Minister. So looking to inequalities or areas the doctor was highlighting, she was discussing regional disparities. For instance, in one type of tumors, there are some areas in the Czech Republic where the inequality is great, and social area, diagnostics, common diseases compared to rare diseases, availability of innovative medicine, and so on. So looking how to do that, I would say it's hard to achieve the social improvement. I guess that you are doing quite well in the other areas, but maybe we should include other areas, other ministries than Ministry of Health. Would you mind to comment it briefly? Yeah, I apologize. I need to open another conference now, so I will be away for 9 minutes, and then I'll be with you again. Thank you very much. Thank you very much. So we will then involve you fluently. So, yes, you are right. This area is something at the interface of Ministry of Education, Ministry of Social Affairs and Labor and Health, and I think we should also involve the State National Public Institute for Health and so on, and other stakeholders that should be involved. Nevertheless, this area is definitely our weakness for a long time already, and we should improve the situation. Nevertheless, frankly speaking, I cannot explain what and how. We will just improve the situation in the upcoming months. Okay, let's leave it alone. We will not focus on it during our conference, but I really liked when the first speaker described individual area. So thank you very much for your explanation. And now our doctor is away, but she will join us later. But now I would like to invite Professor Jiří Majer, chairman of the Czech Society of Hematology, head of the Internal Hematology and Oncology Clinic, which is the inequality of care in individual areas we have probably discussed. So the floor is yours. Thank you very much for invitation. Thank you very much for giving me the floor. When I have seen your beautiful presentation, which in a smart and flexible way, but in a serious way, also highlighted the situation, including potential troubles. I have just said that we can spend a week talking, discussing about all those issues, and we still have topics to discuss. I have made a couple of notes, and definitely we will have a chance to comment it later on. I don't have any comments on the formal presentation. Nevertheless, I would like to touch upon several areas, and maybe later on during the discussion we can just focus on it in more details. Nevertheless, we got a number of interesting topics. The most important topic is inequality. And I would say that we face number of inequalities in general terms. Inequality, and I have made a note, we can talk about so-called global inequality, whether Europe generally, while adopting the state-of-the-art therapies, is maybe more conservative compared to USA. And then we got other inequalities on a local level or state level. But we should not forget it. We have discussed it informally with Deputy Minister Mr. Dvořáček, but we have to admit that we also have inequalities within hospitals. During some reasons, some specialties have worse and some others have better positions due to a number of reasons. As we have seen, the lung tumors map or different aspects of lung tumors. Czech Society of Hematology had prepared a partner project, a national hematological oncological program that become part of the national oncological program, which is quite logic. We are part of oncology, and we had several objective data from the health statistic office. Still, we are a small country, 10 million people, few square kilometers. But speaking about incidence and prevalence, we have witnessed dramatic differences. Some regions were highlighted in darker colors. Some other districts were highlighted in lighter colors due to a number of reasons. Probably it is not due to the fact that patients do not exist, but probably it is due to the fact where the intensive hematological oncological treatment centers are located. Should I say the general view on the Czech hematological oncological situation, then I think it's not bad at all. We should not lie ourselves. We should not say that nothing is rainbows and everything is wrong and so on. No, it's not true. Looking to certain criteria, for instance, number of allogenous transplants of different types per 10 million inhabitants, then Czech Republic is not leading. Nevertheless, we are doing relatively well. Then I think it's really important, and it has been already explained partially because we did not have enough time for it. If a certain state is capable to publish own scientific research data in good journals, then I would say it demonstrates the general level of the given specialty, not only from the healthcare point of view, but once you conduct translation research, you have to have patients that are treated in high quality procedures and so on. And I think that Czech Republic is really doing quite well. Especially, we got two clusters of offices, one in Prague, the other one in Brno, and every year they just publish really good articles, several good articles in high-quality magazines annually. Then, on the other hand, I have to admit there are certain specialties that in fact, shows room for improvement. There are a lot of buts. I don't want to be too optimistic. Now, the lawyer of the medical faculty, we have worked with him on one project. He had sent me yesterday findings of the Constitutional Court focusing on complaints of several senators related to availability of medicines and complaints about centers. When we have learned about it, we were in fact quite horrified once we read it, and maybe we are the only society within the Czech medical Society association, I have learned new notion amicus curiae, and it was already repeated in this finding. So I would say centralization is really important due to a number of aspects. You cannot obtain experience in all treatments locally. Nevertheless, true is that the geographical presence of the centers is not equal, and we already brought some solutions in the National Cancer Plan. It's not necessary to build new centers, but definitely as we have, for instance, regional oncological centers, so maybe we should go this way. What is, however, a big topic, the hematological oncological area has never been supported by any grants in the past. Capacities are not enough in many aspects. We have heard about increase of number of patients. Well, some diagnoses can be transferred from the oncological acute treatment to chronically ill patients. For instance, diabetes, it's also a chronic illness, and nobody is surprised hearing that. But we have to admit that some infrastructure is really neglected, and grants, support schemes will be really needed in those areas. Speaking about transferring patients, it is not happening. For instance, in the regions, they are asking us whether they can take over non-catchment patients, even though we have a freedom of choice. And I think it can be tackled quite easily if the management of hospitals it's involved and so on, so provided we got some grant schemes, subsidies, database. It has been explained well. It's a separate area which should be probably discussed intensively. Number of databases and data already exists. Nevertheless, linking specifically patient with specific laboratory results or with complications and so on, it is not that easy. Well, for instance, Czech Society of Hematology maintains one database. It's quite complex, and in fact, we don't have any financial subsidies for that, so we constantly have to ask for financial assistance and so on. And I have to say that it is not, for instance, 100% perfect. Then Section 16 approaches of the health insurance trusts reimbursing in different way, different same drugs and so on. Then for generic medicines are supposed to be reimbursed in different schemes compared to the original medicine, but in fact it's the very same molecule, and it leads to true chaotic situation. For instance, physicians do not have user-friendly medical systems quite often. Then the revisions will come, and the hospital should return some money. So, for instance, very same drug is associated with different protocols. So, for instance, different strengths. 100 milligrams is associated with a treatment protocol, while 50 milligrams B treatment protocol. It's like a cooking book. For instance, if you add sugar, then lower quantity of sugar all over quantity of the active substances should be associated with Section 16. So it is also inequality. To summarize it, hematological oncological treatment is not doing that bad, but it's at the edge, speaking about capacities and investment. I'm not talking about inattractiveness of this specialty. Also from the nurses or physicians' point of view, we face number of troubles and we have to solve them. Otherwise, the scissors between the developed Western world and Czech hematological oncological situation will keep opening. They are already open.
Professore.
Thank you very much, Professor. And if I may, I would like to delve a bit on regional availability. How do you see that? What's your perception of it? Do you think that patients are closer to a given center prevail, and the further away a person is, the further away that person is from treatment? Or is distance a factor that doesn't play a role, and are there other factors that are more important? So, for instance, referrals, etc. So related to that is also a question, if I've understood correctly, capacity-wise, it's on the edge. Patients are coming, new and new are coming, so it's just like a batch production, isn't it? Serious production. So how do we address that? This is a clash, so we need to centralize. The centers should focus on the treatments and do that well, but availability should be retained, and this is something, a riddle that you've been trying to address or solve, haven't you? I don't think that distance really matters that much. There are multiple aspects to it. Usually, centers and the district workplaces that are dedicated to different aspects of care cooperate. There are, for instance, workshops organized jointly, people know one another, etc. And even though it's not anchored anywhere in legislation, we pursue shared care. So a doctor in an outpatient clinic spends a few hours a day phoning his colleagues from the centers, etc. And especially where there is, say, one center for quite an extensive regional area. We can't really afford that when, for instance, they have acute leukemia or some other difficult case. Then we can't afford not to admit that patient. Where there are several centers, patients may be told to phone, say, a different one, check if they have free capacity. So sometimes the patient cannot be admitted there and is then taken on by a different regional center. The Hemato-Oncology Society has been addressing that question. As for increasing capacity, well, I can perhaps compare it with Škoda, the Škoda cars. So, for instance, they are producing a certain model, and everything is running very well. And perhaps it's then possible to transfer the know-how elsewhere. It's fairly easy. So the production of cars can move elsewhere. And you may think, well, here we have, for instance, a high demand for cars, but we should establish a new car manufacturing plant. But that would be nonsensical, because to start from scratch wouldn't be as easy as transferring that elsewhere. So if, for instance, you were to allocate an amount worth 10 units, be it millions, billions, or whatever, and spend it on a center that works well, it can dramatically improve performance. If you, however, wanted to start from scratch and establish a new such center, then you would need to invest not 10 such units, but tenfold that much in not just funding, but staffing, etc. And I'm not exaggerating. But I believe that, for instance, the bone marrow transplants and other procedures, some often comprehensive procedures, and the follow-up care, this is one of the most complex medical procedures. So you have to have highly specialized methods available, both in terms of screening, examination, treatment. So it doesn't really pay to start from scratch. So I believe it's worth the while to support the existing centers or possibly discuss the establishment of oncology centers with hemato-oncology care, extended hemato-oncology care, but naturally there would have to be stringent accreditation criteria that would have to be followed. But naturally, region is in charge of regional health care, and we can't ask the president of a region to have that unless he or she wants to. So thank you for the answer. Not an easy one, but you never give easy answers. Thank you for your answer anyway. And let me now approach Professor Marek Swoboda, Director of the Masaryk Cancer Institute in Brno. You focus on solid tumors. My question is the same that I asked Professor Meyer. What's your perspective on inequalities of care? Thank you very much for the question, and thank you for opening up this theme. It's vital from regional, national, as well as European perspective. We've seen France and Germany on the map here. In some regions, they also have issues with screening and availability of certain medicines, etc. So ensuring accessibility and availability is key. It's about the perspective you have about the objectives that are set. The EBCA offers certain targets. So, for instance, the HPV vaccination of teenagers or number of patients that should receive center care, etc., sharing health data, and so on and so forth. So the EBCA is clear on all that, and the Czech Republic has already started very well on that journey. And then besides that, we have to define certain targets ourselves. The 27 member states are different in many respects, so we have to define our own goals. In solid tumors, a fundamental target for us that has already been achieved, and certainly the journey has not been easy. You may remember Professor Wolicek, Associate Professor Prausova, etc. So a journey of many years, which, however, has succeeded in achieving us ranking 11th now, and this is something we can be proud of. So we have a network of comprehensive cancer care centers. But what needs to be improved is the adherence to the prevention programs. We have screening centers, high-quality methodologies out there. However, the screening of the population is around 60% of the population, even less. So a lot to improve in this respect. It's about health literacy. We need to focus especially on certain groups of the population who then don't get to use certain prevention programs. So it's a role for health insurance companies, among others, to take on. I believe, and this is one of our main tasks, is to be not just among the first half of EU member states, but to retain our position there. So that has to be our mission. And we should remove inequalities. So, for instance, one rare disease in solid oncology, neuroendocrinous tumors, we cooperated with health insurance companies and producers to make sure that patients don't need to receive PRRT therapy abroad, but in our country. In diagnosis, we have established codes that can bring precise diagnostics, and we can improve the efficiency of medicines in the respective indications. In precise oncology, there is still room for improvement. So, for instance, some programs that can go beyond the standardized administration, etc. So, still room for improvement, and I would like to, however, highlight one thing in this context. You can have availability of medicines as best as it can be. You can have well-equipped hospitals, and we do have well-equipped hospitals, both in terms of equipment and staffing. However, the system itself may not lead to efficiency, so it's a certain discrepancy that we see. So, for instance, discrepancy vis-a-vis the north of Europe. Unless our indicators are well defined, it may happen that if a patient with poor prognosis is not detected early on, and, for instance, sees a GP, is referred elsewhere, etc., instead of being diagnosed as quickly as possible. We need to speed up access to diagnosis and treatment. There are gaps that we need to fulfill. Thank you very much, Professor. And let me follow up on what you've mentioned. So, quality indicators, preferred patient pathways. This is what you hinted to. Is this contained in the plans, the National Oncology Plan, or do you communicate that already? Is this something that will be addressed in the near future? Some indicators are already contained in the National Oncology Plan, and they are expected to be included in the EBCA, in the discrepancies register, inequalities register. It can be simple indicators such as mortality, not just mortality of oncology diseases, but post-surgery mortality, for instance, pancreas carcinoma, etc. So, yes, there are some indicators already out there, and other indicators have made their way into the National Oncology Plan. We also need to identify indicators for waiting times, so determining diagnosis and starting treatment, that should help dramatically. And then there are things related to patient organizations. So, for instance, carry out regular patient satisfaction surveys, also monitor adverse effects of treatment, monitor patients, and use that for screening patient needs, offering targeted help and assistance of their issues caused by the treatment, etc. So all that is part of the EBCA. Thank you very much. And now, if I may, I'd like to approach the director of the General Health Insurance Company, Mr. Zdeněk Kabátek. I have one question for you. If you look at availability, we have looked at it, and previous speakers have looked at it from various angles and aspects. And if you would like to put it in context with the current development of the financial situation of health insurance, is the care perhaps a luxury? Do you think that we'll have to address other things, and perhaps oncology therapy will be an extra? Well, this is a provocative question for sure, but I just wanted to ask you, do you think that you'll be able to fulfill all these ambitious targets outlined by the EU or by the Czech Republic? And can you perhaps also specify vis-a-vis outlook for the center care? So what do you think will be the bottlenecks there? So the floor is yours to answer. Good morning, ladies and gentlemen. Thank you very much for invitation to this roundtable discussion. Oncology long-term has been one of the main priorities for the general health insurance company. Well, I will speak only on behalf of our health insurance company. We have more than 300,000 clients with costs of more than 17 billion crowns, just to illustrate the figures. I won't really say anything totally different from the previous speakers. The Czech Republic is one of the countries where the care for oncology patients is of a very high standard, and I hope that the approach of the General Health Insurance Company has contributed to that. Well, I'm not running away from Mr. Tickett's question, but as we are discussing inequalities, disparities here, besides social disparities, where we can't really be a stakeholder to solve that. In all the other issues, we have the competences and we have the instruments to strive to fulfill the targets on which we all agree, and I believe that the other health insurance companies agree on that, to have prevention and high quality and safe treatment for patients. We have discussed availability in terms of capacity, regional availability, etc. So a lot has been done in the last few years. We have a functional and well-set network of comprehensive cancer centers that cooperate with one another. These regional oncology centers. So this proves that not just us, but the Ministry of Health has been addressing this theme long term. I can perhaps mention the Karlovy Vary region. So it doesn't have a comprehensive cancer center, but the surrounding centers can take care of patients from that region. We discuss where our steps should be directed in order to support this network of centers and to use them with as high efficiency as possible. We take part in discussions concerning investment in the technical equipment. Czech oncology centers are equipped with state-of-the-art technologies, robotics, etc. Then indeed state-of-the-art equipment. So that is progressing at a very fast pace. We keep up the pace with the rest of Europe. And in innovative medicines, again, there is nothing to be ashamed of. And I'm already getting to Mr. Tickett's question. In at least the past 5 years, the General Health Insurance Company could use resources that we have at our disposal. We use these resources that we've obtained thanks to our efficient management, and we can now spend them on innovative medicines. This is actually related to Section 16 and, well, the unequal use of this section has been mentioned, but I dare say that we have made sure that all the providers can be certain that when they indicate a medicine, that it will be reimbursed pursuant to Section 16. So predictability and swiftness of response has improved dramatically. So again, nothing to be ashamed of in this respect. There are also new methods, new innovative medicines out there, precise medicine, I took part in one conference in Brno dedicated to that. So all of these are challenges that need to be met. But on the other hand, I believe that we have the staffing and technical capacities and capabilities so we can meet those challenges. But now really getting to Mr. Zicker's question. The years 2020 and 2021 distorted the system significantly. So these were exceptional years. We had to address ad hoc situations related to the COVID-19 pandemic. What's, however, positive is that over the whole 2 years, and this is especially thanks to doctors and management of these large centers, that the most costly care and treatment provided in these centers wasn't affected in any way. So I'm pleased to know that treatment was continuous without any major impacts of COVID-19. What, however, has been impacted by COVID-19 was prevention. Screening programs, prevention programs, which actually payers implement from the prevention fund. So there we have seen a decrease in the volume of right care, so decrease in screenings in the prevention funds. We saw that COVID-19 has impacted that. Not that capacities would be blocked dramatically, but rather the behavior of clients has been changed. So many people feared going to the screening programs, going to the public, etc. So we really saw declines by a few percent or even dozens of percent. And now really to answer the question, in spite of uncertainties of the future economy development caused not just by COVID-19, but also from February onwards, with respect to the situation in Ukraine, naturally that has had a negative impact on the whole of Europe, and that will, this will have an impact on the economy too. So in spite of all these developments, as we've outlined and made it clear, we're ready to do everything we can to make sure that our clients still receive the care and treatment they should do. Well, naturally, it would be just empty words if we didn't have the instruments to implement that. So we have the resources from previous years that we generated. I often hear arguments that, the system is about to crash, etc. But I can assure you that the General Health Insurance Company has, at this moment, sufficient reserves, so we're not planning to change our standards of behavior vis-a-vis, our cost policy, etc. And we also naturally follow the reimbursement decree, etc. And in the mid-term, we want to keep up that strategy. So really, we are not going to reduce the access of clients to the standard of care. So really, in no way is that going to happen. Besides using the reserves we have, we'd like to maximize the efficiency of reimbursements in Czech healthcare. There is, again, room for improving the organization of care and treatment for clients, so we can achieve certain savings there, curb the costs there, again, to keep up the trend of ensuring good access of our clients to care. We cooperate with the Ministry of Health. We discuss naturally what implications the refugee crisis will have, how that needs to be addressed in the Czech Republic. Perhaps I'm a bit weird, but I'm slightly optimistic as opposed to others. But I think we'll really manage this situation in cooperation with Mr. Dvořáček and the whole Ministry of Health. We have a rational attitude to the whole situation. Often we can hear how various reports such as that, the payments for the state insurance holders, that, these will be frozen and so on and so forth, and the system would collapse. No, I don't think this is going to be the case. We'll manage. You have nothing to fear. And unless there is an extraordinarily extreme situation, there is really no need to be concerned that we would reduce our care and access of patients to the treatments provided.
Thank you very much for positive message. We were pleased to hear it, and of course we are eager to hear how the positive valorization will look like. It's great that the director of the greatest health trust is an optimist, which gives hope to everyone, I would say. Then I just wanted to ask about the regional accessibility, availability. About 2 to 3 years ago, we organized a roundtable in the city of Ostrava, and we also discussed whether oncological treatment is available there, and we heard that we don't have good enough data to find out how patients are doing with respect to access to treatment in the region. They don't have to be treated just in the region. For instance, there are less patients in the region, but they can be treated elsewhere, Brno or Ostrava. I just wanted to ask, do you think those data are missing, or do you already cater for those regional differences? No, I think that recently data are available thanks to the Czech Healthcare Statistical Office. The director, Professor Dušek, collects quite interesting statistical data, which are not related only to COVID, which may seem like recently. We have met with Mr. Dušek recently, not only about primary care, but also about data related to oncology. And I would say that we are able to describe troubles now. Regional accessibility, availability is increasing recently, and together with presidents of the regions, we are able or we try to simply have a holistic approach to the healthcare in the region, micro-region, macro-regions. Professor Prauzová, who is away now, but definitely if she is here, I would say she would definitely confirm that we are meeting monthly on the good treatment delivered to our patients. We try to involve primary care, we try to involve regional oncological centers, and we try to inform clients, patients sufficiently, because quite often the accessibility, availability is influenced not by actual accessible care in the region, but by the informational level of the patients. So it is really important to provide information to patients. It is simply necessary to guide our patients correctly and provide treatment just in the time, which of course improves accessibility throughout regions. Thank you very much. And I guess we have time to hear the voice of patients now. Petra Adamková is the chairwoman of the Voice of Oncological Patients now. You have heard previous speakers when they express their vision on equality of treatment and accessibility of care. How much this is in line with the perception of patients themselves, your colleagues, or do we have any aspects we have neglected to mention? Thank you very much for giving me the floor. Thank you very much for inviting me. Nevertheless, before I just focus on your question, I would like to thank you for inviting patients also. I am involved in this area since 2016, and since then the voice of patients is being more and more respected, and I'm truly grateful for that. So in fact, I wanted to respect respond to Director Kabatek, who really pleased me a lot because he just ended his speech with the troubles and the treatment, which is lack of information, not only about treatment, but informations that are necessary for quality of life, pre-treatment, treatment as such, and aftercare. And of course, it relates to social area, psychological counseling, rehabilitation, after care, and so on, with respect to prevalence numbers and so on. So, in fact, the entire patient pathway we have described, which is also described in the European plan, I think exactly what we miss is the guide of the patient coordination and providing information. Of course, it is related to information literacy, digital literacy, and not only of patients. I just wanted to highlight what was already highlighted during the French presidency. They, in fact, move from patient engagement to citizen engagement or involvement of citizens. Again, it's about communication, education, responsibilities of citizens for their own health, and it is related to oncological treatment also and holistic approach of the oncological treatment. Generally speaking, when patients get ill, they don't know there is a complex oncological center where the best treatment would be provided. Patients on his path does not know a lot of information, and this is a contribution of patient organizations and supportive organizations that make the patient's pathway smoother. So I see the professor being here also. Recently, we work a lot with the Czech Society for Oncology, and we can help each other in order to increase quality of life of oncological treatment to keep it as long as possible at high level. Thank you very much. Now, I just would like to ask you one more question. Let's think about pathway of one specific patient. Let's neglect wider aspects you have mentioned with respect to French presidency. That means the citizens' involvement. But let's imagine we have a specific patient with a specific troubles. Who should be the patient guide? Who should inform patient about, let's say, patient organization and so on? But once the patient is registered in the system, and I think that also in the oncological areas, maybe some centers are overloaded. Maybe they don't have enough time to talk in details with patients. Well, I know the situation in Prague, only not in Brno. And sometimes guiding the patient is somehow missing, neglected. Sorry to interrupt my speech. I would like to welcome Professor Vorlíček, the Emeritus Chief of the Czech Society for Oncology. He is, in fact, one of the reasons of our successes. And I remember when PhD Vorlíček had highlighted how important it is to communicate with patients, how after the Velvet Revolutions, physicians visited USA and so on. And nowadays, it seems that maybe the caseload of patients is too high, and physicians maybe don't have enough time to talk to patients. Have you been thinking about it? Yes, we have been thinking about it. In fact, the Voice of Oncology Patients was established last autumn. Beforehand, we acted as a free platform, but our task is to map the patient pathway in individual oncological diagnosis, simply to map individual pathways per diagnosis, what information patients are provided with, whether patients are referred to, again, referring to Europe's Beating Cancer Plan, whether patients are informed about all those aspects that are important with respect to inequalities. Our organizations, or in fact, generally speaking, organizations in the Czech Republic do not cover all oncological diagnoses, and we would like to act as an umbrella organization for all oncological diagnoses. So, of course, we would like to find the best way, of course, in cooperation with the Ministry of Labor and Social Affairs, Ministry of Education, and so on. It was already mentioned how important it is to communicate in the social affairs and so on. For instance, we got a social health interface work group already. So we are aware of that, and we will just use the negotiation and involve everybody, all stakeholders, in order to fulfill the National Oncological Plan. Thank you very much. I would like to welcome PhD Prausová, who managed to get back to us. So I just would like to ask you, a lot of important topics have been discussed, but I have no doubt you know all of that. I just wanted to maybe highlight that the director of the General Health Insurance Company, Mr. Kabatek, is also interested to cooperate with the Czech Society for Oncology, and they actually do cooperate with them. So we were talking about the accessibility, availability of care in oncology. And so may I ask you, what are the strengths and weaknesses in your view? So good morning again. I have been with you during your conference, so I had listened to all papers of your panelists. As already suggested, Czech oncology is in good shape. Great event was centralization to comprehensive oncological centers that was made within a radiotherapy and system therapy. And then I just wanted to mention one trouble which needs to be handled, which is the centralization of surgery care. Of course, surgery care is quite unique by its acute feature. And of course, I don't want to deny that we should centralize surgical care. I think we should create high-volume centers, which are groups or teams of surgeons that will primarily handle very important severe diagnoses and complex surgical protocols. And it does not have to be available in all comprehensive oncological centers. Those teams should be accredited according to groups of surgeons' skills, and teams that are able to provide post-surgical care, especially in anesthesiology and resuscitation, rehabilitation teams, and so on. That's the task which is really important, and it is already happening in lung oncological treatment, gynecological oncological treatments, and so on. And it's definitely the right move forward. The other trouble is to get patient in time from GP to a center that is able to provide adequate care. As we were arguing or complaining about COVID, and we still think about it, but COVID pandemic allowed us to start this online communication, which is definitely not full-fledged communication, and it's not pleasant, probably. Nevertheless, it is good for the speeding the multidisciplinary team actions, which are in fact very important centers or core of our treatments, because if we don't have something, then it's time. We don't have enough time. And online we can discuss with regional teams about their patients. It's a simple thing. You don't have to simply do it during the first meeting, but it's the first step of the patient pathway. So we know about the patient, it's registered, and the patient is sent to the patient pathway, either to be treated in a region or in comprehensive oncological care, depending on the severity of the illness. So that's why I would like to highlight digitization of the Czech healthcare, set parameters of documents, because of course we need to set clear structure of data which will not consume too much time, and also creating multidisciplinary teams that would be focusing on some severe diagnosis, severe surgery protocols or radiotherapeutic protocols. And it's no problem, in fact, to refer patients to multidisciplinary teams where specialists from all corners of the country will work. GP may be part of this multidisciplinary team if recognizing that time is really sparse and we need to speed up the treatment. For instance, ultrasonic biopsy of pancreas, carcinoma, tumors like that. You have a number of those illnesses where we have no time. If we wish to speed up the patient pathways from the regions to the centers, remaining patients inadequately diagnosed or inadequately treated, then we need to use the data environment and digitization and interlinking those offices. It's not complex. We are also talking online now. So it's about willingness to work online also. Of course, we need to be aware of the GDPR data protection, but I think this is the first and basic step and also objective of the availability of adequate care across the entire territory of the Czech Republic. We don't have to establish multiple centers. In contrary, we may specialize some centers on certain diagnoses, converting them to super centers focusing on, let's say, rare diseases or less frequent diagnoses. It's about interlinking of social and health care system. We can, and we have discussed, and I can confirm that we have, in fact, already worked with the director of the General Health Insurance Company, Mr. Kabatek. We are regularly on touch. We keep promising ourselves that we will meet in person, but we don't have enough time. But thanks to Mr. Bell, we are in touch. Well, the truth is that we can virtually discuss. Nevertheless, patients cannot be virtually treated, and we need to refer patients to the centers. And that's about the ambulances or accommodations of patients in the region or location where the treatment is conducted. And they don't have to stay necessarily in hospitals. So what we have to focus on the social aspects is the ambulance car a social need or therapeutical need, and both ministries, Ministry of Healthcare and Ministry of Labor and Social Affairs, should participate, and we should discuss on the payment scheme. So that's the first issue, and second issue is how to cover payment for accommodation for patients where he is treated. They don't have to stay in hospitals. Hospital beds are really very expensive, but patients can stay somewhere in some hotels. maybe with the support of the social allowances. So there are a number of ways how to arrange it, and there is a will, there is a way. So in the central Bohemia region, we are inviting physicians to one clinical day to the teaching hospital in Prague 5 model, and we are simply referring our patients to them, and we just give them, our patients, full palliative care. So I really think that we have already named ways how we can handle it. We just do work with Professor Liška, Professor Vašáková, and PhD Votruba in the area of diagnosis and treatment of lung cancer, where I would say we are most advanced in the super treatment pathways. And we have opened one office in Prague model already, hospital. Thank you very much. Dr. Kopečková, when she described different types of inequalities, she also described, and maybe it's about our thinking. She suggested there may be inequalities between patients with frequent illnesses and rare illnesses, diseases. Is it also true for oncological patients? Is it relevant to comment it?
I believe that rare diseases, this theme is addressed in a sophisticated manner. So it's less frequent diagnosis, but the issue is the same. To get these patients as fast as possible to a dedicated center, it's about awareness here. We have managed to raise awareness about the super team. That is this multidisciplinary team involving various hospitals, such as the General Teaching Hospital, Motol, Nahomolce Hospital, etc. So there, this team is for lung diseases. And when we, for instance, raise awareness in a similar manner about rare diseases, so for instance, Professor Linke does the gastrointestinal tumors, and there is a multidisciplinary team already up and running. Well, what we need to do is to inform people about that, and well, if a simple email is sent, then we can discuss the patient who is concerned. Thank you very much for the specification. We have touched upon new therapies several times with fantastic opportunities, but these therapies are also quite expensive. Well, here, Regina Demlova, Associate Professor, dedicates her attention to assessing these therapies and how do we then define what provides value of money and what not. And certainly such debates will be important going forward too. We have discussed various aspects of an equitable access to care and treatment, and we're now moving to the finals. Mrs. Demlova, may I ask you, what are the paths leading to ensuring availability and making sure that it's also sustainable in light of all these fantastic opportunities offered by state-of-the-art medicines? Well, with sustainability in mind, so that only sensible and efficient medicines are reimbursed. Thank you very much for the question. Thank you very much for invitation to this roundtable. Previous speakers have already slightly touched upon this. I'm involved in clinical pharmacotherapy. So let me answer your question straight away. If we had unlimited possibilities in terms of funding, it would be very simple. The director of the General Health Insurance Company has said that we have resources, but certainly they are not unlimited or endless. in order to be able to evaluate results or outcomes, as we should say, we need to think about the data sources. We have data sources from clinical trials and evidence-based medicine builds on that, and the therapeutic recommendations are based on that. So these are the robust clinical trials that bring data, which actually were enough up to a certain point in time for a number of medicines, or nearly all medicines that we have in clinical practice and those that are reimbursed. Randomized clinical trials have brought the answers to everything. What, however, is becoming a challenge, and oncology is an example of that, is a certain segment of highly personalized therapy, precise oncology. So indication of these medicines is, for instance, based on specific mutations, which, are just for a specific patient. So we need to have different data rather than from these robust, large-scale clinical trials. We need to have data from the actual clinical practice. Where are these data? Do we have them? Do we not have them? Do we need to collect them separately, as Professor Meyer has hinted to, or are these data already available in the registry of reimbursed services? And certainly it's in the hospital information systems, but again, it's not actually with any parameters, and it can't be shared simply as a result of that. So in the near future, what should be done is to open up this sharing, so that would be, the fairness principle, so that we can utilize the data. We also need to harmonize the hospital information system, but I don't think that this is going to happen in the near future. As for utilizing data that the health insurance companies has, that the State Institute for Drug Control, SUCL, has, etc. So yes, again, that's something that's already available. And for certain types of medicines that can't enter the system easily, should be analyzed, subject to the outcome-based modeling, where we can have information about outcomes of specific patients with specific mutations. And again, there are not dozens, tens of thousands of such patients, but only very few of them. So that's one thing. And then we should discuss how to actually share the data, how to make use of the data, and is it the payer, the health insurance company, the ministry, the oncology center who should say that that data should be obtained and shared? That's a topic for discussion. Thank you very much. And may I ask you, Mrs. Demlova, who should be interested in working with the data? Probably all. So who should be most interested? Well, probably everybody. It's just about perspective. So even a specific doctor is interested in the data when he or she wants to publish results, and so it's one thing. Then it's various medical societies. It should be also the patients who would like to see whether treatment is efficient or not, how much it costs, etc. But if you ask this generalized question, I'd say that it should be the health insurance companies, the payers, who should inform about these outcome-based models or performance-based schemes for specific types of medicines. Not all. We have for instance, medicines with standard reimbursement. Once we have the data from pharmacoeconomic model, we have highly innovative medicines, the orphan designated medicines. There is a commission, Ministry of Health Commission, that assesses it in its whole complexity. And there is Section 16, which should only be used in extreme situations, if my understanding is correct, if the medicine would otherwise be unavailable. And then we have what I've mentioned. So we have these precise medicines, and for them, it would be great to use outcome-based models. We discussed it in Brno last week. We established an initiative of comprehensive oncology centers with molecular tumor boards and register. Yeah. Overarching that, we'd like to collect data because it's not possible to obtain that data from the hospital information systems in an automated manner. And so payers and then everybody else should be interested in these outcomes. And also with respect to advanced therapies, where clinical trials are not robust and the number of treated patients are quite small again. So how would you envisage the payer to be interested? What should the payer do? What can the other side do? Doctors or somebody trials or somebody assessing therapy. So what should happen between the payer and your initiative? It's a two-stage process. In the first place, and when there is a high degree of uncertainty as to what the outcome-based model, what impact it would have on the whole system. So that's really not in phase one. Model data should be brought in this stage or phase one. So we agreed that in Brno that we'd like to have the data in a year or in a year and a half. So for medicines that are now approved using Section 16, we could, however, discuss whether with the Oncology Society we may perhaps request the payers to have a precision approach to this platform of the medicines. And then based on the results that we monitor, we'd like to bring to the payers and present retrospectively the outcome-based model so that we know what the volume of funding, what 2 or 3 model cases look like. The outcome-based model naturally has to define the outcome in the first place. However, I believe that the Oncology Society has so many renowned clinicians who can agree on that. So there will be a consensus, undoubtedly. So the first thing is to bring the data, and Director Mr. Kabatek was at our conference. I'm very happy that we could discuss that this is an approach that could be functional. So if this model is in place, then I think that health insurance companies should identify medicines where an outcome can be defined. And for these types of medicines, in cooperation with the producers and holders of registration, they would agree on an outcome-based model. Mr. Kabatek, would you like to comment on this from your perspective? I wasn't expecting this question. But anyway, I took part in the conference. I think that this is the right path that we're on. What is missing is the full digitization of Czech healthcare. It would be best if data could be obtained automatically. But we're interested in such data, and I believe that this could be strong arguments for concluding risk-sharing contracts based on payment on the basis of effect. So I welcome those efforts, and we intend to cooperate further. Thank you very much. And now, any of you is free to respond to anything that has been mentioned here. Professor, the floor is yours. I don't want to take up much time here. I think I've spoken enough, but we opened a very important theme, and that's data and data analysis. It is interesting to note that in Czech healthcare, all data practically are in the form of zeros and ones. I don't think that there is an elderly GP with a typewriter. No, but I think that the data is in some sort of digital format already. And I, in the past, had a discussion with Adam Wojciech. He had a team for quality in healthcare established, and we discussed how data should be collected and analyzed. And what I said, and really nothing changed about my opinion, I said, if you want to make a revolution in Czech healthcare, and perhaps you may think that I've gone mad. Well, no, I haven't gone mad. I'm sure that you'll actually see the reason behind it. Just like we have a toll payment system, for instance, that each and every lorry has to respect. If we would be able to somehow mandatorily introduce in Czech healthcare a single information system, and I would like to underline what Associate Professor Prausová has said, that would be parameterized, from which you can obtain the data. We, for instance, have a DOS platform system in our hospital, and you can extract nothing from it. However, for instance, if you would like to buy a simple wide wooden cupboard, you put it on Google, you get the outcome immediately. However, if I wanted to do the same with the hospital system, I would have to use, say, specialized gastroenterology terms, etc. So if we had that single information system, all that we have, the patient pathways and whatever the waiting time was, and whether an adequate examination was performed or whether a non-adequate examination was performed, leading to a non-adequate result, and so on and so forth. The patient had to schedule another appointment, and it went round and round. Whether, for instance, a tumor was identified, and then the patient was told to seek a surgeon to perform an operation, and so on and so forth. So all that is in the health records of the patient for sure. But it's as though the skies are overcast, and if the data became available, it would be like the sun started shining. I don't think I'll live to see that, because surely if there was a public procurement on that, then many people would probably go to court and be jailed afterwards, and I don't know what. But and I would also like to mention one other thing that was, other theme that was open up, like accommodation of patients. They could be accommodated somewhere to receive treatment in the centers. Well, some beds also were occupied by patients on palliative care, so that's another aspect. But in state-of-the-art foreign hospitals and centers, information systems with parameters are available. So, for instance, if someone has acute myeloid leukemia, you have the survival data available straight away. When I was in the cancer center, Mecca of Oncology, where I really wanted to go to see how it operates there, and it's a number of years ago when I went there, there was a car park for 40,000 cars, and there were Hilton hotels and other more or less luxurious accommodation facilities surrounding that, and patients hospitalized were really severely ill. Otherwise, they wouldn't be hospitalized there. So there are many things that we need to discuss, and we shouldn't do it just like step by step, create further and further registers. But I employ several admin workers in our clinic who only rewrite data from one pseudo database into another database. That's absurd. We have, for instance, well, these little cars traveling Mars, and still we have this in hospitals. So we have data in completely unutilizable form, and this is something that really, really needs to be given a deep thought. Thank you very much. Thank you very much. In Zdravotnický deník, we have been addressing long-term the issue of data in healthcare, so certainly we'll go back to that question. But let's perhaps go back to the beginning, and let me hand over to Mrs. Kopečková, after the discussion that we've had, if she would perhaps like to look at the individual types of inequalities, disparities, the ambitious EBCA and the Czech Republic. Where do you think the biggest problems will be? What do you think will be hard to achieve for the Czech Republic? Or are you an optimist, and do you think that we'll be above the standards among EU countries? Well, I am an optimist by nature, I must say, and I believe that the mechanisms that we have discussed will help us greatly to fulfill the objectives of the National Oncology Plan. What I would like to highlight, and this is what Associate Professor spoke about, would be to get the patients to the centers where correct diagnosis and correct treatment is received. That's really the most fundamental aspect. And then the second theme that the Associate Professor spoke about, we haven't mentioned tumor-agnostic care. This is something sort of like hiding behind precise medicine. So it's the tumor-agnostic medicines that we have an issue with getting to the patient. So that's why in my presentation I just hinted to qualianizer methodology and need to change that. Thank you. Thank you very much for reminding us of this theme. Would anybody like to comment on that, whether you think that we should review something? If I may, Associate Professor, please.
So I think that everything what we have discussed here, and we would like to implement primarily what Associate Professor Kopečková, Professor Mayer, what I've discussed, and Associate Professor Damlová. Please give or delegate more responsibility to specialized association. They have restricted responsibilities and powers currently. Let us act. During the last year, it will be 1 year already, we have managed to create a basis of a national oncological plan and program that is simply a must for the National Recovery Plan. Without this plan, Czech Republic will not be granted any financial subsidies. We have done it in the premises of Ministry of Health free of charge because we are enthusiastic and we were able to advance more than I was hoping for. In fact, we started to argue at the beginning, people argued that the national goal we have, that means breaking the centralized oncological centers will be lost and so on. So that's how we started. Nevertheless, we have managed to find a compromise and we are able to move things forward. Just please listen to us, give us premise where to discuss. We'll find time, and we are called National Council for Implementation of Cancer. We were assigned by the former Minister of Health. We would be able to invent a lot of useful features if you listen. I mean, if founders, payers, and management of hospitals listen to us, and we will all be taken seriously, then we will achieve a lot. What we want to achieve is to advance both hematology and oncology in the Czech Republic. Please give us a premise, listen to our voices, and listen to us. We just don't need a lot of money. We just want to see it makes sense, and it will really motivate us to work even rather. So please do not dissolve a council that already exists. I have to say that I have just called to the ministry and ask for not dissolution of the council. We should continue. We are really able to find end-to-end solution. Just allow us to do so. So we will just interpret your call to the others, responsible ones. Yes, definitely, and maybe I would, in fact, build on Associate Professor Pausova. We need to contain this plan and check Society for Oncology, in fact, introduced this notion. The reason is simple. All those disparities and inequalities are associated with number of stakeholders, and nobody can solve it individually. We need to find a consensus, and we need to build a relevant framework, maybe a ministry. We have simply decided for the National Council for Implementation of the National Oncological Plan, asking me what I find most important for the Czech Republic to remove disparities nationally, not regionally. We definitely need to improve digitization and smart solution. It is not perfect yet, even though recently a lot of hopeful projects were introduced, and maybe COVID pandemic had accelerated it. But still, we have a lot of data that are not structured, not associated with parameters. So, in fact, it's an e-record, blind one, and we should really improve digitization of health, and we should really enrich it by social services because it's a useful interface. Then the other area is prevention. We have good programs, accessibility, and so on. And I have to say that the adherence to preventive programs is quite low, but I think that definitely we should involve payers of the care, regulators of the care, and patients themselves. Specialists may deliver feedback, but we need to have a will and commitment of those most important players, otherwise we will get still. I think that a lot of tasks that Europe and Czech Republic wanted to promote, it's quite wide. We have a lot of challenges, and we would be pleased if we manage to fulfill a lot of them, most of them. So time is running, and I then leave interesting discussions for lobbyists. I would like to thank Mr. Kabatek, Director of the General Health Insurance Company, the President of Czech Society for Oncology, Mrs. Prausová, Professor Mayer, Chairman of the Czech Society for Hematology, then Director of the Masaryk Cancer Institute, Brno, Professor Svoboda, then Associate Professor Regina Demlova, the head of the Institute of Pharmacology, Faculty of Medicine, Medical University of Brno, then Dr. Kateřina Kopečková, Deputy Head for Science and Research of the Oncology Clinic of the Second Faculty of Medicine of Charles University and Motol Teaching Hospital, and then, of course, Mrs. Adamková, Chairwoman of the Voice of Ecology Patient Committee. Questions? We need microphone to interpret it. Then we open Q&A session now. So please hold with us. I apologize. I have to run to the Ministry of Health. So thank you very much. I'm sorry for not opening Q&A session before.
For my question in English, Julien Daguerre from Novartis. A question on the cancer plan. Is there anything around precision oncology? It was mentioned a lot today that this is important. Anything in the plan to develop access to NGS or to create networks in the country to increase access for patients? Thank you.
Prosím, pane profesore. Děkuji.
So if I understood correctly, precision oncology and NGS, correct? Okay. So actually, Hematology Society of the Czech Republic worked on this topic quite intensively in the couple of last years. And for some diagnoses where having NGS results has deep impact on prognostic stratification of patients or to selection of appropriate therapy, it is now routine and it is routinely reimbursed by health insurance companies. But I would like to emphasize it was quite a long journey. It took a couple of years, but I think for a reasonable proportion of patients when we really need these particular results, it's routinely available. Moreover, I would like to mention that last year, our working group, Czech Leukemia Study Group for Life, CEL, organized informal comparison of different labs because still it's a tricky procedure. Different labs use different devices, different kits. Also, the results reports is at different level. So we would like to contribute to the standardization of these results because it's quite important when you then would like to collect the data, link this molecular data to the patient outcome and so on. So you need a little bit some kind of standardization. Thanks.
Děkuji pěkně, ještě paní docentka Demlová by doplnila.
Thank you very much, PhD Adamova.
Is really the specific part of the European cancer plan, but at least on the national level and in solid tumors, we decided that for us it's a big challenge, and we established the Genesis platform. That's what I mentioned between the complex oncological centers with the established molecular tumor boards, and we will collect the data and we will do many applied research. I mean clinical outcomes research in this part.
Maybe just one thing to add. Yeah. If I'm checking the national cancer plan, there is a direct point which is pointing the implementation of the NGS technologies in the Czech Republic. And as Professor Meyer and Docent Demlova said, mostly it's done. Mostly now it's in all the comprehensive cancer centers and comprehensive hemato-oncology cancer centers. They are connected to the laboratories which are capable and able to do the NGS for the particular purposes. Another way is, and that was my correction to the National Cancer Plan, we would like to much more stronger mention the flagship of European Cancer Beating Plan number 6 and number 7, which is much more focused for personalized cancer therapy, to be also in the Czech National Cancer Control Program. So that's something what actually will be a part of our Czech National Cancer Control Program.
Děkuji. A ještě jednou se omlouvám auditoriu, je to opravdu příliš.
I apologize once again. Any other question? Yeah? Okay, let's leave it for the lobbies. I would like to thank very much everybody. I would like to also thank to the Association of the Innovative European Federation of Pharmaceutical Industries and Association of Innovative Pharmaceutical Industries. Thank you very much and see you later.